Okay, why don't we go ahead and get started? Good afternoon, everybody. We'll take down the music and we'll go ahead and get started. So good afternoon, everybody. Welcome to this third annual Daniel Blumenthal Lectureship in Health Equity and Social Justice. My name is Mirza Rahman. I'm the president of the American College of Preventive Medicine, and I want to welcome you all here to the National Press Club as we go ahead and get started. First of all, thank you to all of you who've made the effort to come and meet with us here in Washington, D.C. And I also want to thank the staff who's put together a terrific presentation. We also have a live stream of this event. And for folks who want to share it later, they'll be able to do so with friends and family. In May 2017, Dr. Daniel Blumenthal was president of the American College of Preventive Medicine. And the conference that he organized in May of 2017 was called Achieving Health Equity Through Prevention. This was really emblematic of who Dan was. As the president of the FACPM, he put together keynote plenary speakers and so on, focused in 2017, not post-2019, not post-2020, 2017, looking at the social determinants of health, and he created the theme for the conference, which was Achieving Health Equity Through Prevention. Unfortunately, less than 2 years later, Dr. Daniel Blumenthal would die suddenly in 2019. And his death was then followed by the events of COVID, the murder of George Floyd, and the emergence of a heightened focus on social justice and its relationship to health. At that time, the president of the college, Dr. Stephanie Zaza, wanted to honor Dr. Blumenthal's legacy to educate our profession, colleagues throughout the health and medical enterprise, and decision makers in every aspect of our profession on this issue and the relationship between social justice and health. And Dr. Daniel Blumenthal Lectureship was set up to address structural racism, health equity, and social justice. Now, many members in the audience here and those online can talk to us about personal stories and their experiences with Dr. Blumenthal. I'll just share two with you. I had been a member of the Finance Committee for several years in the FACPM. And in that May 2017 meeting in Oregon, Dan talked to me about considering running for treasurer. Now, I've had great folks who have mentored me. I've been fortunate. I've had great role models. And it was just great to have somebody like Dr. Dan Blumenthal ask me to do something like this. And sometimes people see in you more than you see in yourself. And Dan's support and Dan's, putting this forward helped me to think about how I could lead the organization. So if there's anyone to blame for my presidency, I'd start with Dan. And I think the way that Dan lived his life is really something that we should try to emulate. It's about putting prevention into practice. So he worked at Morehouse, and he had been there for decades. And at the Morehouse School of Medicine, he had retired, but he still continued to work. So it's a historically black college and university. But he's professor and chair in the Community Health and Preventive Medicine Department, and he still continued to work even after he had retired. So to me, that's emblematic of Dan. It's a life of service, and I think that is something that we should recognize and try to emulate. And then as president of FACPM, I wanted to share that starting in 2020, we as an organization look back and inward and trying to figure out things that we needed to address, and also outward, how we could push ourselves and change and become better to deal with the challenges of social injustice and health. And this is how this lectureship was set up. So today we will hear from Dr. Kamara Jones, our awardee and then we will listen to a panel of distinguished experts as we look to connect the dots. As Steve Jobs says, you don't connect the dots forward. It's only by looking backward you can connect the dots. So connect the dots and see what we can do. A lot of, unfortunately, diversity, equity, and inclusion initiatives are a lot about talk or performative work. And to me, as I talked about when I became president back in March in New Orleans, it's not about talk, it's not about sharing theories, it's about doing. It's about concrete opportunities. And so it's about carving out deliberate action steps to ensure we dismantle structural racism and use our positions to state the truth and to get done what needs to get done. So it brings me great honor to introduce the 2023 Daniel S. Blumenthal Lecturer and to extend this honor and award to Dr. Kamara Jones. Can you bring it up, please? We promise we'll ship it to you. Now, before I formally introduce Dr. Jones, let me share that I was fortunate as a young man, and I know looking at all these gray hairs, you can never believe I was once young. But in the early to mid-1980s, I was a student at the Sophie Davis School of Biomedical Education at the City College of New York in Harlem in the city. And we had this young, energetic family doc who came, and she was teaching in the Community Health and Social Medicine program, and that was Dr. Jones. And it's just a delight to be able, almost 35, 40 years later, to be able to introduce her. And serendipitously, we have with us another former graduate of Sophie Davis. We have Dr. Helen Burston. So we have another Sophie Davis person. So Dr. Jones, MPH, MD, PhD, is a family physician, epidemiologist, and past president of the American Public Health Association, who recently returned from England. We're going to be listening for that English accent. And was the Leverhulme visiting professor in global health and social medicine at King's College London. Her work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of our nation and the world. Her allegories on race and racism illustrate topics that are difficult to otherwise understand, and that racism exists, racism is a system, racism saps the strength of the whole society, and we can act to dismantle racism. Dr. Jones taught 6 years as an assistant professor at Harvard School of Public Health, developing the school's first course on race and racism, and served 14 years as a medical officer at the Centers for Disease Control and Prevention, leading the development of the 6-question reactions to race module for use on CDC's surveillance system. As president of the APHA in 2016, she launched the association on a national campaign against racism that catalyzed the first of what are now 260 declarations by local jurisdictions across 41 states and the District of Columbia that racism is a public health crisis. Since she shared her experience on race and racism and anti-racism, it's been extended to residencies. She's a Radcliffe Fellow, worked at Harvard University 2019 to 2020, was a Presidential Visiting Fellow, worked at Yale School of Medicine, and numerous other things which I won't go into. But she is an elected member of the National Academy of Medicine, an elected member of the American Academy of Arts and Sciences, and commissioner on the recently launched O'Neill Lancet Commission on Racism, Structural Discrimination, and Global Health. Dr. Jones earned her BA in molecular biology from Wesley College, her MD from Stanford, and both her Master of Public Health and her PhD in epidemiology from the Johns Hopkins Bloomberg School of Public Health. She also completed residency training in general preventive medicine at Hopkins and in family medicine at Montefiore, where I had met her shortly after she had done that. Now, please extend a very warm ACPM welcome to Dr. Jones as she gives her lecture on health equity. Dr. Jones.
Well, good afternoon, everyone, and I am so honored by you all at ACPM, but also honored to be receiving something in the name of my friend, Dr. Dan Blumenthal. So I'm just going to say 3 ways that he has affected my career. The first was when he was the section chair of the medical care section at the American Public Health Association, and I'm thinking this was maybe 27 years ago, and he invited me to come and become active in that section because he said, if you're active in this section, you can become active in the association. And that actually, I would say, culminated in my being elected president of the American Public Health Association. So thank you, Dan. The second is when he had already retired from being the chair of the Department of Community Health and Preventive Medicine at the Morehouse School of Medicine, but was still teaching in the first-year medical student course, the community health course. And he reached out to me while I was still at CDC and invited me to come and be one of the course directors in this program that for a year, 3 hours every Wednesday, we would take a small group of students into the community. So I worked with him and with my very good friend, Gail McCrae. And we were a lovely team. So again, thank you for introducing me in that way, Dan, to the Morehouse School of Medicine. And then finally, when I was elected president-elect of the American Public Health Association, he was president-elect of the American College of Preventive Medicine. So I remember one of the last kind of lunches that we had out, when we were plotting, if you will, what were we going to do together with this power of presidencies kind of focused at Morehouse School of Medicine, because by that time I was over there. And so I know, Dan, I hope that you can hear us, and Marjorie and anybody in the family. I really appreciate you, Dan, and I'm so honored to be receiving something in your name. So anyway, so now I will talk. And I am going to spend, well, I'm not going to tell you how much time because then you put your clocks up. Sometime before our panel, talking about confronting racism denial, naming racism and moving to action. And now I recognize that what I miss is like a monitor or something. So you will see me looking up just to make sure I'm at my right place here on the slide. So I hope that's not distracting. So the first thing I want to say is that I have articulated 3, which I introduced as 3 principles for achieving health equity, which I now recognize to be 3 principles for a just society. And they are valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. And I'd be happy at some other time to go deep into how do we operationalize these, but I think we can all recognize that these are principles for a just society and that racism interferes with us achieving any of these in our current society. So recognizing that, in 2016, as president of the American Public Health Association, I launched our association, and as many other communities and partners, so AAFP and many other organizations. I launched us on a national campaign against racism with 3 tasks. The first task being to name racism. Why? Why do I say we need to say the whole word? Because racism, first of all, there's so much active and staunchly held racism denial in our society, right? That there are many people who would say racism doesn't exist. But even for those of us who know racism exists, if we're working on diversity, equity, inclusion, belonging, structural competence, cultural humility, race, all of these things, and we work on all those things without saying the full name, the full word racism, then we're complicit with the racism denial that's so staunchly held by so many in our society. And you must name a problem in order to get started on the solution. So the first of these 3 tasks for a national campaign against racism is to name racism. But as necessary as it is to name racism, it is necessary but insufficient. We have to go beyond naming racism and move to action. So the second of the three tasks of my national campaign against racism is to ask the question, how is racism operating here? You will notice I didn't say, is racism operating here? Racism is foundational in our nation's history, right? The question is, how is racism operating here? And why does that start moving us to action? Because it is the landscaping for early targets for action, early levers for intervention that might be within our reaches. How is racism operating here in my child's daycare? How is racism operating here in my workplace, in my practice, in this community, in this nation, in the world? Right? And when you start, I'm going to give you some tools for answering that question. So I'm not just like, how is racism operating here? Okay, good luck, figure it out. I'm going to give you some tools on that. But after we do that landscaping, recognizing that, yes, we do have individual power, each of us. So we have the individual power to put things on agendas, to speak up and take action on behalf of others, to hire students. We have lots of individual power, but we need to organize and strategize to act, because collective action is so much more powerful than individual action. It informs us, it inspires us, it propels us, it protects us. So these are the three tasks for a national campaign against racism that I proposed in 2016. And you heard in my introduction that my 2016 efforts catalyzed the first in Milwaukee County of what are now 262 declarations that racism is a public health crisis by local jurisdictions and the like. Like number 150 and number 200 and number 262 may have never heard from Kamara Jones, but I know that the first and probably the first 10 were basically responding to this work. That first of the three steps is perhaps the hardest for us to get traction on in this country. In fact, when I talk about racism denial in our country, we have so much evidence that right now in terms of Supreme Court decisions, in terms of laws being passed across the states that you can't study history, or even taking math books out of the curriculum because they highlight, mathematicians of color and that kind of thing. So the first thing is to name racism, and when we name racism, there are 4 key messages in doing that. The first is that racism exists, okay? The second is that racism is a system. The third is that racism saps the strength of the whole society. And the fourth is that, yes, we can act to dismantle racism. So I'm going to spend my time with you this afternoon sharing 2 of my allegories, my teaching stories, to illustrate. All of them have a little something to do with all 4 messages, but the first one I'm going to share with you is going to really be a tool that you can use with others to say, remember this image and then understand that racism exists. And the second of the 2 allegories I'm going to share with you is to help us understand that racism is a system, and recognizing that racism is a system, we have to recognize we must address racism at the system's level if we're going to make things right. So I don't have time for all the others, but anyway. So here's the first story. And this one, like most of my allegories, especially my early allegories, is based on something that happened to me in my own real life. So I call this one Dual Reality, a Restaurant Saga. It helps illustrate that racism exists. So step into my shoes as a first-year medical student. And as a first-year medical student, I know I was diligent and very studious, so I woke up on the Saturday that this thing happened to me, like on most Saturdays, and what did I do? I hit the books. I started studying immediately, and it was already mid-afternoon, and some of my friends had come over to the apartment, and did they distract me from my studies? Oh, no. They were medical students too. So what did we do? We all got together studying long and hard. And by this time, it's getting later and later, and we're getting hungrier and hungrier. And I had no food in the apartment, which was so typical of me that my friends actually understood. They were like, oh, yeah, Kamara, we got that. You don't have any food in here, but we're hungry. So let's go into town and find something to eat. So that's what we do. So we walk into town, we find a restaurant, We walk in, we sit down, the menus are presented, we order our food, and the food is served. Here we are eating. So back in the day, if I were telling this story in my generation, you might have thought, if I'm saying racism exists, it's a story about a restaurant, that we weren't served. But indeed, we were served. So now you're starting to get a little confused. Well, Kamara, where are you going with this story then? Hold on. As I sat there with my friends eating, I look across the room and I noticed a sign that was a startling revelation to me about racism. So now I hope I've intrigued you and you're wondering, okay, Dr. Jones, what did the sign say? Well, what did the sign say? The sign said, open. So now I know I've lost many of you. How is a sign that says open a startling revelation about racism? So let me recap. Here we are sitting in a restaurant eating. I look across the room, I see a sign that says open, thinking no more about it. I assume other hungry people can walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that indeed the restaurant was now closed due to the hour, but firmly closed, and that other hungry people, just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food, and eat. And that's when I recognized that racism structures open, closed signs in our society, that racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant, at the table of opportunity eating, and they look up and they see a sign that says open, they don't recognize that there's a two-sided sign going on because it is difficult for any of us to recognize a system of inequity that privileges us. Wow, I went through a lot of things. That went really fast. Anyway, there it is. It's difficult for us. Okay, so you got the punchline before I said it. Sorry. Anyway. It's difficult for any of us to recognize a system of inequity that privileges us. So it's difficult, for example, for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege in the global context. Although we have seen it so many times, I'm not even going to go into the examples now. I mean, I'll just say, the way that we sequestered so much of the global supply of COVID-19 vaccine at the beginning, in this country was an example of that. Those on the outside, however, are very well aware that there's a two-sided sign going on. Why? Because the sign proclaims closed to them, but they can look through the window and see people inside eating. So, back inside the restaurant, to those who do ask, is there really a two-sided sign? I say, I know it's hard for you to know, when you only see open, does racism really exist? Well, yeah, it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if you do why, you could even talk to the restaurant owner, who is, after all, inside with you. And you could say, restaurant owner, they're hungry people outside. Why don't you open the door and let them come in? You'll make more money. And oh, the conversations we could have. Or maybe what you'll do if you're sitting inside that restaurant and you care about those on the other side, maybe you'll pass some food through the window, or maybe you'll try to tear down the sign or break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign that proclaims open to you. So when I share this story, if I have 5 minutes to share a story with a group, especially a group that might not even understand, that might have grown up their whole lives feeling that this is the land of equal opportunity, then this is the story I shared that says, yes, racism exists. It's structuring two-sided or multi-sided signs. It's structuring a dual or multifaceted reality. But also for those of us who really know that, yes, racism exists, this is a little image that we can share with our family members or our colleagues or somebody on a bus or on a plane to help them understand the two-sided nature of, when you even think about it, there would be no need for an open sign if it were not a two-sided sign, right? So anytime somebody is reassured by a proclamation of openness, then they are missing the point. There's no open sign in the wilderness, like if it's really open. Anyway, I will say, you guys, are you with me? You guys are just like, I mean, some of you like, I mean, I know it's 3 something, but anyway. So I will also say that I have used this story. I have actually started by asking the question, how could people who were born inside the restaurant know something about the two-sided nature of that sign, and sparking what on 2 occasions were 3-hour-long conversations, because there are many, many ways for those people to know. I am heartened that more people who were born inside the restaurant and just 3.5 years ago might have been sitting inside eating and maybe craning their neck. What are those people outside saying? Black lives matter. Don't they know all lives matter, right? More of those people are actually now saying Black lives matter. More of those people are saying the word racism, putting together the phrases structural racism, systemic racism. This is important, but here is my warning. For all of us, if all we do is say a thing, it's what you were saying, Dr. Rahman. If all we do is say a thing, put something on our institutional websites, or maybe Instagram or tweet or Facebook if you're still, whatever it is, if we just declare I am anti-racism or whatever, if that's all we do, 6 months from today, we are at risk of forgetting why we said that thing, because racism denial is so staunchly held in our society and so seductive that we might fall into what I describe as the sleepiness, the somnolence of racism denial. So we must go beyond just saying a thing, naming racism, to action, which means we need to maybe tear down the sign, but of course racism is not just a sign, it's a door, it's a lock, there's a whole system going on. We need to dismantle the lock, take the door off the hinges, and I tell you, once we start acting, we will not forget why we are acting. This is the power of action, right? So let me carry on and just share with you, I've said the word racism about 30 times now. What do I mean when I say the word racism? I'm clear when I say the word racism that I'm talking about a system. So I'm not talking about an individual character flaw or a personal moral failing or even a psychiatric illness, as some have suggested. And yes, racism shows up in all of those ways and many more. But in its essence, it's a system of power. And a system of doing what? A system of doing 2 things. A system of structuring opportunity and of assigning value. And on what basis is the opportunity structured and on what basis is the value assigned? It's based on so-called race, based on the social interpretation of how one looks, which is what we call race in our society. And I could do a whole lecture on what is race, but we don't have the time. But I will say that this socially assigned race, this is the substrate on which this system, racism, operates day to day, right? I will also say, so I'm about to go into the hour-long talk, but I need to say this. In most parts of the United States, you look at me and I'm clearly black. In some parts of Brazil, you look at me, I'm just as clearly white. In South Africa, you look at me, I'm just as clearly colored. I have been in those places, I've experienced this. So here I am, same physical appearance, but the social interpretation of my appearance in those 3 settings would assign me to 3 different racial groups. And furthermore, if I were to stay in any of those settings long enough, then my health outcome and educational outcomes and income outcomes, wealth, would take on that of the group to which I've been assigned, even though I'd have the same genes and behaviors in all of those places. And it's not just because I'm a so-called light-skinned black woman. For every one of us in this room and in the sound of my voice, there is some other place on this earth where your so-called race will be quite different from how you are living it today. So it's very important for us to know that race is not written in our genes. We have genetic ancestry, yes. We have cultural ancestry and parents and grandparents and great-grandparents behind us, and we have language and history and all of those things, but the thing we call race is something that is assigned to us in a race-conscious society based on, in this country, based on facial features and hair texture and color, and each race-conscious society has different things. So I just needed to stay there. So this thing that we call race is the substrate on which this system, racism, operates day to day and has operated across the centuries. Racism has impacts. When people in this country recognize that racism exists, then they understand, oh yeah, racism is unfairly disadvantaging some individuals and communities. But it shouldn't take any of us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege in our country, which we hardly ever talk about because it makes some people, especially some people who are living as white, uncomfortable. And I used to, in a room like this, I might say something like this, and I see people start to twitch or, shift in their seats, and I used to almost apologize for what I perceived as some discomfort at that little acknowledgement. And I'd say, oh, if you feel uncomfortable, shake it off. Stay with me. I'm going to tell you more stories. I don't apologize for that discomfort anymore. What I say is, if you feel uncomfortable acknowledging the reality of unearned white privilege, I encourage you to lean into that discomfort by reading more, read history, go across town and stay a while, talk to strangers, and the like. And why do I say that? That's a kind of sassy thing to say. It's because I recognize that for all of us, the edge of our comfort is actually our growing edge. But there's a third impact of racism that many of us miss, and that is that racism saps the strength of the whole society through the waste of human resources. And we see it when we don't vigorously invest in the full, excellent education of all of our kids, because we think, or the leaders who don't do that investment think there's no genius in the barrios, ghettos, reservations, when of course there is genius in all of our communities. And if we were to only vigorously invest in that genius, we could be doing so much better as a nation or a world. There are many ways that we sap the strength. I won't stay there. I will carry on to say that that definition of racism that I just shared with you can be generalized to be a definition of any system of structured inequity. So what is sexism? That's a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. And I acknowledge that there are many axes of inequity operating in our society today, intersecting in communities, intersecting in individuals. And these are all at least risk markers for how opportunity is structured and value is assigned, even as some of them are also risk factors in the progression to disease. So then people say, well, oh, Dr. Jones, you recognize all of this is going on? Why are you so focused on race as the axis of inequity and racism as the system of structured inequity? And my answer to that is very clear. Racism is foundational in this nation's history and wealth. And yet, as I keep saying, many people are in staunch denial of its continued existence and profoundly negative impacts on the health and well-being of our nation and the world. So when you have something like that, I actually believe that all of us need to at least be actively anti-racism. And I don't say anti-racist, because if I said, let's be anti-racist, and somebody heard me, they'd be like, oh, is she talking about me? No, I'm not against people. I am against a system. Let's all be actively anti-racism, even as we also engage in as many of these other struggles around these other axes of inequity and their associated systems of structured inequity. And to the extent that we're able to dismantle the mechanisms of racism, the other struggles will benefit as well. But when you have a situation that you have something that's foundational in your nation and yet people are in staunch denial of it, we all need to focus our attention there, or we will never have any action on it. I will proceed to say I recognize that in this country, in the world, in this room, there are many people who value comfort. And in this country, in the world, in this room, there are many people who value social justice. You can hardly see that. Can you see that? Okay. And in the current status quo, valuing comfort and valuing social justice are at polar opposite ends of a value system. I'm not saying that you can't be comfortable while you're working towards social justice, but if your value system, the thing that motivates you is comfort, unless you are expanding the comfort to be comfort for all of us, right, and not just me, my family, or whatever, then valuing comfort and valuing social justice are at polar opposite ends of a value system. And I have come to understand that those who value comfort are very much like those who were born inside the restaurant, sitting at the table of opportunity eating. They value comfort because they benefit from the status quo. They are made comfortable by the status quo. They are not wondering why nobody else is coming in. They may not even notice because they are so focused on their food and the conversation in their small company, right? They certainly don't want to examine the sign. In fact, in this country, state by state by state, they're passing laws. They may have heard somebody say, oh, there's a two-sided sign going on. It does actually say closed on the other side. They're passing laws that say that you can't even examine history or talk about equity or racism or any of those things because it might make their children uncomfortable. They don't care to know what the outsiders are saying, and they don't believe that an outsider could add anything to their conversation. So, you know, they may have been told that your little table here in the restaurant needs to diversify. So they'll say, okay, we'll bring an outsider in just so that we can have a better picture. But they don't believe that that outsider would bring genius and creativity and leadership and all to their proceedings. They don't wonder how the food they're eating even got there. They don't recognize that the people on the outside who can't come in and eat are the same ones growing the food, transporting the food, bringing it around to the kitchen, cooking the food, serving the food, but still cannot sit there and eat. And finally, they do not want to budge from their seats at the table. They very jealously guard their privilege, which they don't even understand as privilege, but instead feel is an entitlement. Now, those who value social justice, on the other hand, value social justice for two reasons. They know two things. They know that there's a two-sided sign going on, many of them because they were born outside and they saw it say closed, but they can look through and see people inside eating. But they also know that the operation of the two-sided sign saps the strength of the whole society. I am not suggesting that the circumstances of our birth completely determine our value system, and I recognize that there are people who were born inside the restaurant, but who do wonder, why aren't more people coming in? What are those people outside saying, and whatever, and they make their way to the other side of the sign, and they experience our common humanity in very different circumstances. I recognize, and they see that it's a two-sided sign, and I recognize that there are those who've been born outside the restaurant who, through dint of lots of hard work and lots of degrees, MD, MPH, PhD, whatever, and make their way inside. But sometimes the promise that they have to make when they make their way inside is that they will never mention the fact that they even saw that there was a two-sidedness to this sign. Once they get inside, usually they're put near the window so the other outsiders can see them, and sometimes they use that position near the window to also be near the door, stick their foot in the door to keep it ajar to make it easier for others to come in. But sometimes they are the worst gatekeepers and they fortify the locks. We could have lots of conversations about who, what, and movement here and there. But what I want to say about this is that part of our job is to move more people from valuing comfort to valuing social justice, even as we recognize that you will not always or maybe ever be comfortable when you become a social justice warrior. Okay. I'm just going to quickly say I can't tell you my Gartner's Tale. If you've never heard of the Gartner's Tale, it's a paper I published in 2000. Here's you can go to the CDC 2002 video of it. You can see it on my TED Talk or whatever. Speaking of my TED Talk, I do lots of storytelling. So my 2014 TED Talk has Japanese lanterns that helps us understand race is not biology. I just share it with you, dual reality, racism exists. I refer to you to the levels of racism, Gartner's Tale, because that helps us understand racism on 3 levels, and furthermore, that if we want to set things right, we must at least address the structural level in order to make things right. And then Life on a Conveyor Belt, Moving to Action, which helps us understand and motivates us toward those 3 parts of anti-racism action: naming racism, asking how's racism operating here, organizing and strategizing to act. But the second story I'm going to end with is not on that 2014 TED Talk because it's newer than that. So this is the second story that many of you will never have heard. It's called Cement Dust in Our Lungs, and it helps us understand that racism is a structure. When I say cement dust in this story, I want you to think cement dust, and I also want you to think racism. So imagine that there's a cement factory spewing cement dust, and the cement dust fills the air. And if any of us are anywhere near this factory for any amount of time, we're going to develop cement dust in our lungs. Now, that cement dust in our lungs is problematic for all of us, although it might affect different ones of us differently. Maybe cement dust in my lungs makes me feel I'm less than. Maybe I shouldn't try to graduate high school or apply for that job or live in that neighborhood. So the internalized oppression or internalized racism, and maybe the cement dust in somebody else's lungs makes him feel that he can, with impunity, crush the life out of another human being with his knee for 9 minutes and 29 seconds. But however it's affecting us detrimentally, even for those people who don't know that they have or wouldn't recognize or admit that they have cement dust in their lungs. So what are we going to do about this problem? Well, should we focus on the individual? Actually, the cement dust is in our lungs. Well, what would that look like? Here are going to be 2 interventions that focus on the individual, and I will critique each of them. But what if we have some kind of screening machine, and it screens each one for how much cement dust they have in their lungs, and then an alarm goes off if you have too much cement dust in your lungs. Well, okay, how much is too much dust, right? What are we going to do with those where the alarm goes off? Put them on the edge of society? Like, what are we going to do? But the biggest problem with it, so it's good. The good thing about this is that for people who do not believe they have cement dust in their lungs, at least it will make them aware that they do. So that's a very good thing about it. But the biggest problem with it is it makes people not even want to talk about cement dust at all. So let me just say racism. If we had something, like the IAT or whatever, like in our society, people don't want to say the word racism because they think if you say that word racism, you're going to try to peer deeply into their soul to say exactly how racist are you, right? So that's a problem with that approach, although it has the usefulness of letting people know they have cement dust. But say there's somebody who says, oh, I have cement dust in my lungs and I want it out. Well, we could actually set up cleansing spas, right? We could have trainings, and people could volunteer or be voluntold to go in, read history and the like, and come out as good as new. But when they come out into that cloud of cement dust, the dust is just going to reaccumulate in their lungs, so it's not a very permanent solution. And I just said something that might help us get to the next level. When they come into that cloud of dust, maybe what we need to do is acknowledge the cloud. So what does that look like? So when we acknowledge the cloud, at least I recognize that I was not born with cement dust in my lungs, right? And it makes me think, well, if I could put on a gas mask, right, start my individual anti-cement dust journey, then maybe, at least I won't develop more cement dust in my lungs. I know it won't, in and of itself, extract the dust that's already there. I know I have to keep it on 24/7 because if I just take it off for a minute, more dust will come in. So I actually get a little encouraged when I see myself reflected in a glass or in a mirror that I have my gas mask on. So, that's an individual anti-cement dust intervention, but the good part of it is when you see me, you'll say, Dr. Jones, why are you wearing a gas mask? And then I say, oh, do you see all this cement dust in the air? Do you want to know how to do that? And so more and more will say, yes, I'm going to put on my gas mask. I'm going to start my individual anti-cement dust journey. And that's all good. And maybe that's the answer, right? Maybe we just need 330 million gas masks. Little baby gas masks, old people gas masks, all kind of gas masks. Well, it's a start. But what I think we really need to do is dismantle the factory. So those of us who have started our individual anti-cement dust journeys, have the gas mask on, we can probably even see a little clearly. We need to get closer and closer to that factory, which actually has been obscured by all of the dust that's thrown up. Some people don't even know there's a factory in there. And then when we get close enough, we need to ask, how is this factory operating here? And then we need to organize and strategize to act to dismantle the factory and put in its place a system in which all people can know and develop to their full potentials. So this little image helps us understand not only is racism a system, but we must address racism at the systems level. It's good to address the other levels too, but must address racism at the systems level in order to set things right. The question that I ask, how is this factory operating here, is the analog to the question, how is racism operating here, which I introduced to you earlier. And it's a legitimate question because racism is not a miasma. It's not a cloud that we can't get a handle on. It is a system with identifiable and addressable mechanisms which are in our structures, policies, practices, norms, and values. And I just gave half of this room a headache. Structures, policies, practices, norms, and values. Dr. Jones, what am I supposed to do with that? It feels like that until we recognize that these are actually the elements of decision-making. Structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. And I beseech each of you in the sound of my voice, the next time you sit at a decision-making table or set one, and henceforth, your first job is to look around and say, who is not here who has an interest in this proceeding? And then you don't just represent their interests, which you might have to do in the short term, but what you're trying to do is create space to find them a way to the table. And if structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices are the unwritten how of decision-making here and now. Well, no, we didn't write it down, but just watch me. You'll see how we do things. It's much harder to discern because it's not written. Policies is where most people go when they're trying to do some kind of analysis of what's going on. Even though with policies, people don't often say, well, what's not here that could be put in place? You know, we're very, very just what's in our face, you know. But anyway, practices are the unwritten how here and now. Norms are the unwritten how, but deeply embedded, and how we expect you to go and act going forward. And values are the why of decision-making. And it is my experience that if you want to say, how is racism operating here with regard to this policy or in my workplace? If you spend just 5, 10, 15 minutes thinking about who's at the table, who's not, the who, what, when, where, why, and how of decision-making, you can identify 5, 10, 15 promising early levers for intervention. So this is like a real thing. I do that when I'm asked to do talks and topics that I have no idea about. And then I present my ideas, and people are like, oh, yeah, yeah, and then it stimulates them to fill in the blanks, okay? So anti-racism, I talked about racism. Anti-racism is a process with the same 3 tasks that I introduced with my national campaign against racism, and you see that the steps are sequential. You need to name racism, then you ask how is racism operating here, and then you organize and strategize to act. But here's the funny thing. Once you go through that once, are you done? No, sir, no, ma'am. It's iterative. So once you go through once, then you need to name racism again still, because people will be saying, oh, but we have a policy on that. Or that's so 2020, or so 1965, or so 1865, or whatever they're going to refer to, right? And then you need to ask, how is racism operating here? Again, hopefully you have more people so you have more reach where the here is bigger, right? But also people will have come and undone some of the things that you did the first time around. Right? And then you need to continue organizing and strategizing to act. And then you need to do that again. Name racism as how is racism operating here, organize and strategize to act, which means we are not engaged in a 3 to 5 year enterprise, and actually this work may well span generations. But that doesn't mean we shouldn't start or be involved. This is our time. This is where we are on the planet right now. So we need to be doing this work, right? Even though we recognize we may not see the end of the work, but we have to be part of it. But what can we do today to close? Going back to my image from dual reality, the first thing we have to do is look for evidence of two-sided signs. Actively look. Is there something differential going on here by race, by gender, by language, by immigration status, by zip code, by religion, by all of these things? Looking not only at outcomes, but also at opportunity structures. We should never be beguiled to think, oh, well, it looks open to me. As I said, if it looks open to you, it is closed to somebody. The second thing we need to do is to burst through our bubbles of experience to experience our common humanity. What do I mean by bubbles, our bubbles of experience? Well, all of us are in a bubble of experience. We have our families, our jobs, our travels, whatever. Some of our bubbles are vast with thin soap bubble boundaries. Some of our bubbles are smaller with thicker plexiglass boundaries. Some of our bubbles, no matter what their size, have been tinted. Some are polarized. In this country, so many people's bubbles are being hardened by fear. But whatever kind of bubble we live in, many of us do not know that just across town, there are other people who are just as kind, funny, generous, hardworking, smart as we are, who are living in very different circumstances. We need to create at the individual and institutional levels bubble-bursting opportunities so we can experience our common humanity on the other side of town and then start building common cause. We need to be interested in the stories of others, believe the stories of others without requiring cell phone video documentation, or God forbid, police body cam footage. And then we need to join in the stories of others. We need to develop a sensitivity to see the absence of. This is one of my superpowers. I have 2 superpowers, maybe 3. One is storytelling. The second is the absence of, and the next one is being unafraid to ask questions. But that seeing the absence of, we can all cultivate that. Who's not at the table? What's not on the agenda? What policies are not in place that could bring about social justice? We need to reveal inaction, lack of action in the face of need, because that is how structural racism very often shows up these days. But all the power is not just inside the room. And those of us who are on the outside need to know our power. We need to recognize that action is power, and especially that collective action is power, because collective action informs us, inspires us, propels us, and protects us. So I will stop here because I have no idea what the time is. I had a little bit more I want to say, but hopefully in the Q&A I'll be able to share that with you. So thank you very much.
Thank you very much, Dr. Jones. Now we're going to have a reaction panel. We have three panelists who are joining us here. Dr. Helen Burston, she's the CEO of the Council for Medical Specialty Societies. Dr. Tochi Iroku Malize, she's the president of the American Academy of Family Physicians. And Dr. Neil Kahatsu, who is a past president of the American College of Preventive Medicine, and I think the first president who is of a minority group. Leading this group and being the moderator is Dr. Reed Tuckson. Dr. Tuckson is the managing director of Tuckson Health Connections. He's a recognized leader in his field, and he is honored to have been appointed to leadership roles at the National Institutes of Health, the National Academy of Medicine, numerous federal advisory committees, nonprofit boards, and so on. He's a graduate of Howard University, Georgetown University School of Medicine, the Hospital of the University of Pennsylvania's General Internal Medicine Residency and Fellowship programs, and he was also a Robert Wood Johnson Foundation Clinical Scholar. He's going to sit there until I'm done. He is aching to come. An inspirational leader to many. Please welcome Dr. Reed Tuckson. Thank you very much. I appreciate it.
There will be, I promise, an opportunity for you to raise questions of the panelists and also our keynote speaker. You heard the introductions, and we're a little behind, so I'm going to make sure we just kind of, they're famous. And by the way, each of them are distinguished and each more wonderful than the other, depending on where I started. Let's begin with the obvious question. Tochi, I'm going to start with you, president of AFP. Our society is consumed by tribalism, polarism, heated discordance. The health professions and health professionals are not immune to the cause and the effect in this regard. Why should you as leaders of organizations wade into this morass? And why shouldn't we simply just urge professionals to stick to their knitting and just practice good medicine?
So at the end of the day, racism affects our health, everyone's health. And that's what we do. We're all in this because we want to help create a better community, a healthier community. And if we don't address racism, then we can't truly get to the point of providing health, and not just health, health equity, making sure that it's equitable and accessible to everyone, making sure that it's affordable, making sure that all the things that interplay and act to create issues with regards to health. Those who are inside the restaurant, those who are outside the restaurant, because we know that the health of those who are outside the restaurant eventually affects the health of the people who are inside the restaurant at the end of the day. So it's everybody's business, and that's our job, that's our business. And so that's why it's important for us to be involved in it. This is part of what we do. We go out there and have to address the issues that are affecting the people that we're trying to serve. And this is one of the things that is really, really, especially in this country, embedded in how our healthcare system works.
Great. Helen, same question, but we are aware, I'm painfully aware of a backlash that we're seeing now from prominent physicians with very lofty titles, who are mounting a campaign for anti-woke medicine. And so, again, there is such discordance, such fractionization. Why, as a leader of CMSS, why are you pushing forward here?
I guess I'll flip the question. How can we not? Right? There is a moral, ethical imperative to do this work. You can't have quality without equity. It is simply unjust. It is just everything Dr. Jones just said. We cannot take care of our patients unless we take care of all of our patients with equity. And I think that, and actually Dr. Jones helped us as we were building Equity Matters. Dr. Bonnie Mason, who really led that program and worked with 31 of our specialty societies and program director associations, really referred to this work on race, anti-racism and equity as the building blocks of this work. This is the building blocks. It's as much the building blocks as basic sciences to what we do in healthcare and medicine. And so I don't think we can sit on the sidelines. I don't think this is any less important than biochemistry or anything else that we do in medicine. And I think the pushback has to be, we can't take care of our patients unless we take care of all of our patients. And that the imperative is that we have to take care of all of our patients. And we can't take care of all of our patients unless we really address the inequities and racism.
Neil, same question, from a prevention point of view.
Well, like my colleagues, I think all physicians are focused on trying to advance health and well-being, often at the clinical patient level, but that has to be looked at in context. We actually know that a lot of health is determined outside of clinics and hospitals, as important as medical care is. So that's a starting point. In preventive medicine and our sister specialties as well, we look not only at the well-being and health of patients, but of communities and of populations. So when we look at the broader context, we are part of society. We are given privileges to provide care as part of a much bigger picture. So if we are to be successful in advancing health and well-being, it has to be in this larger context. And of course, I agree with my colleagues and Dr. Jones's comments that we have to understand that racism as a system directly impairs health and well-being.
So Helen, you mentioned and alluded to that you were doing some work in this space, and I know that you have been active in it. Can you describe a bit about what it is that CMS is doing to address this agenda, but also, given the first question that I asked,
yeah.
How are you doing it in a way that, and you used the very important word, pushback.
Yep.
How are you doing the work and not making the problem more worse than it already is?
Yeah, no, I think it's a great question, Rita, and it's interesting. Dr. Jones gave me a structure for the way I was going to answer my question. I think in many ways we've really addressed it by thinking about the structures, the policy, and the practices. So thank you. I think the first approach to this, and I'll use the example of what we did across multiple societies as part of the Equity Matters program that we did with ACGME. And I think the first of that was really the structure. So the structure of the program was we required the president and the CEO of every society to participate. So for example, delighted to have had Tochi as part of that program. So by doing that, the structure meant we put those at the highest level to be in the hot seat for learning and to be accountable for change. We didn't assume it was going to be somebody who was like, hey, you're assigned to work on DEI this week. No. It was the president and the CEO of the society. And as part of that, they had to do historical reflections on the history of racism of their society. They had to come up with a plan of what their society was going to do and share it with their colleagues. And actually, as part of that, now more than 20 societies are still engaged in collaborative work to address that. So that's the first piece. So thank you for that framing. So certainly the structures. Policies, numerous societies literally went in and said, we need to change what our policies look like around nominations. Why do we keep getting the same usual suspects being president? You know, because it's the way we look at our nominations process. One of them literally had the 5 past presidents of the society choosing to nominate the next president. Well, what do you think that next president looks like? You're not going to get a whole lot of diversity. So again, thinking about those policies, thinking about the practices as well. How do you think about, how do you build what those programs look like to build your next set of leaders? We now have a joint program across all the societies surveying what are those programs all of them have for those underrepresented in medicine in their specialty, to advance those, to ensure they become the next leaders in academic medicine, they become the next deans, they become the next presidents of their society. So I think the key thing is really thinking about structures, policy, practices, and values. So, and thankfully, as Dr. Jones pointed out, it is about the generations, but the generations in medicine are really short. So we can really make a difference quickly by really attacking each of those. So thank you for that framework, Dr. Jones.
But I'll come to you in a sec, Tochi, for the same question. But let me just, again, keep pushing on, because I'm an eminently practical kind of person.
Absolutely, so much.
And we're all here, getting it done in real world. And so, for those clinicians who watch the TV news programs that may not be a CNN or MSNBC, have you gotten any pushback from that crowd? And if you have, how have you dealt with it?
I think some of the societies have gotten pushback from that crowd, and I think they have tried to embed it as much as possible in the context of clinical care. And I know that's something that we're going to hear from Tochi shortly. So for example, there's now a lot of work we're doing in the context of race and clinical guidelines and clinical algorithms. That's about good clinical care. I think, again, when you ground it clinically, and it isn't this very sort of, I love the restaurant example, but I could see that being harder for some folks to take in than it is saying, by having a renal equation that leaves people out and not allow them to get transplants because you include race in that equation, it may be easier for some clinicians to maybe wrap their heads around that, I think, than necessarily some of these more effusive, really elegant descriptions that I think Dr. Jones, and I think you need both, but I think for some folks for whom this may be difficult to grasp, putting it in the most clinical terms, I think at times, you're saving lives. You're putting it in terms that people can really relate to, I think hopefully will be helpful. We've seen that again, just recently, American Thoracic Society changed completely the way they're doing pulmonary function tests. Equations that go back to Jefferson, that made Thomas Jefferson, we're not talking we're talking Thomas Jefferson, not like Dr. Jefferson from years ago. But it made no sense, but yet, again, the idea that we were diagnosing African-American patients, they were being underdiagnosed and having much later diagnoses and then not being eligible for either transplantation or life-saving therapies, I think resonate in a way that I think is different. So I think you have much more to say about that.
Well, Tochi, why don't you go ahead and let's narrow, we'll turn the microscope up one notch and go right into one particular society, yours. Okay. How are you, what are you all doing?
The American Academy of Family Physicians. Okay, here we go. A long time ago, we had to address first making sure our members understood what was going on. And so we have our membership, we have a Congress of Delegates where we pass resolutions and policies and elect our representatives, our leaders, and they too all looked alike for a long period of time. Fortunately, at one point, they they realized that we have to get the voice of those who are not being heard. And so this special constituency was created. And that's the National Conference for Special Constituency, minorities, women, LGBTQ, IMG, and new physicians. So that was the group. And they had their own conference separate, a Congress. They created delegates, et cetera. And that was actually where Dr. Jones was pulled in to come in 2016 or so, 16, 17, right when you were president, to come and talk about racism, because that's what they wanted to hear about. They said, listen, this is an issue. And that was, from there, we said, okay, took that information and then said, okay, how do we apply it? And started using these same actions that she's mentioned and put them in, started to work on that. And then eventually created the Center for Diversity and Health Equity. The reason we had the Center of Diversity and Health Equity, and this is before the George Floyd and all this, the reason we had that was that we needed a group, someone to spearhead getting the anti-racism information so that we could teach everybody. We needed to create workshops, so we needed to have the create CME, now make sure that everybody who's on a board, we have a lot of clusters, different committees, had to make sure all of them went through the process. Then now go to each of the state chapters and present the information. All the board members were told, you must go out to all the different states and go and teach this topic so that they know how to not just understand it, how to understand implicit bias, but then also, how do I now take this information and actually use this in my practice or in the setting in which I work? And so that was very important. Then of course, policies. And we review our policies on a regular, any good organization should be reviewing their policies every few years. And so that was now another issue, looking at all our policies and saying, okay, what's good, what's not? What should we change, what should we adjust? All our educational material, and that's been going on ever since. We know doctors like, we need CME, so attach CME to anything that you have, and that's another way to bring people in. But to discuss, when you're saying about those who get pushback, our organization, we're just like, it's made up of people across the United States, so of course that's what we have. We have people who watch many different television stations, all right? And they have a lot of, there will be pushback from different individuals. The way we try to approach it is the same way. We're in DC, and all of you, in order to do the advocacy work that you need to do, for each door, you have the same mission, but the framing is different depending on who you're going to speak to get your message across. And then you also have to actively listen, allow them that space and grace, and then move forward from there. And that's basically what we've had to do. It's just the same thing. It's, and as you said, there may be a way you have to do it. What may work for some may not work for others. Yes, we make people uncomfortable, we'll say it, and they're like, grrr. You say, okay, tell me, let me hear you, what you have to say, bring it on. All right, good. Now, in order for you to have a better, your community to be better, to make sure you're taking care of your population, we love the metrics. When metrics came about, in terms of taking care of your patient population, if some of your metrics are really bad because of some of that population, this is going to help you, right? So there's a way to frame it. So, you have to kind of be a politician in some ways in this, but that's how we've taken all these things as action and items and tried to implement them to make sure that everybody understands it. So the key is making sure our docs understand what it is, and then going out to those who are a little bit resistant and just keep trying. You always, even these legislators that you're going to each year and they say no, 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 at least one day they won't say anything, which is good, and then maybe one day we'll get to a yes. But if they stop, then that's helpful because they're not blocking the progress we're trying to make. Okay. And so that's, so it's just persistence, like you said, generations. It's funny, we get somewhere and then we go backwards and you say, how did we get here? But you have to keep going, right? So
Neil, one of the big challenges that comes out of all of this is being able to talk to somebody who sees the world differently than you, whether that is a physician or another health professional of another discipline, and to use the word, unconscious bias. Mm-hmm. Whoa, wait a minute, what are you saying? What are you accusing me of here? Have you learned any lessons from your experience about how to reach across the divide and talk to someone who sees the world differently than you do?
Yeah, that's a great question. And where do we start?
Where do you start?
And something that I learned that we all have dealt with as physicians is the COVID pandemic. Mm-hmm. So my wife is a retired nurse. She worked in an underserved community as a volunteer in an immunization program that was led by an African-American woman who was a neurosurgeon because she was respected in the community. And I think a first step, the lessons from COVID, as just one example, is to start where people are. What is their understanding? And whether it's a community member of whatever political persuasion or someone in a community of color or wherever, is what do you understand about it? And from there, work with, there's human commonalities that I think we all know. We want our kids to be able to have opportunities, as everyone to have those opportunities, as was discussed so eloquently. people want the same things in many areas. And if you can start from there, I think that's what worked in COVID. There were certain misunderstandings and are people trying to do something bad to the community. So you start from there and say, this is what we share in common. No, we want to help and bring health and well-being, and you have people who are credible, who are of the community. So that's a starting point to win people over who perhaps had a certain attitude. So whether it's a fellow physician who has a different opinion on what racism means and the structural aspects, I think, or whether it's a community member that has a different view of the impact of COVID, starting where they are, start moving forward in areas of commonality. In our specialty, I think it's a great framing, Dr. Jones, that talking that racism is a system. We pride ourselves in preventive medicine as being a system-based specialty and individual. So to combat racism, how do we think about structural approaches, systemic approaches to dismantle racism? So that's kind of our strategy.
So Helen, as we sort of think about what we have learned, are you feeling that over the course of the years that you've been doing this work, that we're making some kind of progress? Or has the world, and again, I think we're in this unprecedented, we are absolutely in an unprecedented era of discord and fractionization. The social media really reinforces our tribalism. Every influence we have reinforces the divisions between us. Are you seeing through the work that you are doing progress, or are we being overtaken by contemporary events and challenges?
Oh, that's such a big question. I was sharing with Dr. Jones earlier, and you probably remember this, Reed. When I was at the Agency for Healthcare Research and Quality almost 20 years ago, I led the first National Healthcare Disparities Report. You probably remember this.
I do.
And I remember thinking, somewhat naively now, 20 years later, wow, we're going to show these stark disparities and things will change. Look how dramatic these differences are. You can't just look at quality. You got to see these, like lift up the hood, see how different things are and people will change. No one, actually the only pushback we got was from the administration who asked us, as you may recall, to change disparities to differences because disparities was pejorative. That's a whole other story. Front page of the Washington Post, leaked, long story. Anyway, and then a few years ago I wrote a paper for the Annals of Internal Medicine when they put out their big report on healthcare reform called, linking cost, quality and equity, and I couldn't believe we still had to write this. But once again, like, can we finally stop talking about quality without equity? Like, we have to utter these in the same breath. CMS is still talking again about how we can finally link quality and equity, and we can't have healthcare payment without talking about equity. So I am still concerned that we don't have good data that actually show us. You asked, are we making progress? From a quantitative perspective, I still have no idea. I don't feel hopeful that we have actually made our data systems good enough, that I feel like we have closed the gap. And in fact, you are probably one of the shining examples of the work you did in COVID, where we actually closed the gap on immunization for African-American patients. And you should be incredibly congratulated for that, because one of the only examples I know of where the gaps in care have been, where the disparities were closed. Beyond that, I don't know of many. Just yesterday, if you listen to NPR, there was a story about, again, at least in DC, about how the rates, I think, among African Americans in DC, men with prostate cancer mortality is 60% higher for African American men in DC. That is a travesty. So I think what's gotten better, and better may not be the right word, is I think the awareness of the issue and the need to weave it into medical education across the full continuum, the importance of us addressing not just DEI and equity, but truly, I think, to Dr. Jones's point, taking on structural racism. I think the elegant October issue of Health Affairs really addressing structural racism across the full board, I think is an awoke, hopefully is truly something that won't just be a flash in the pan. I think this is real, and I think we've adopted it into our system. I just don't know that it's translated yet into true changes in the care we've seen and the way care is provided to patients.
Well, Tochi, one way maybe without a lot of data to sort of assess what the trend curve looks like in terms of are we making a difference with our constituency is the sustainability of your agenda, your initiatives. Are you feeling that, again, given contemporary challenges and all the other things we've got to deal with, whether it's pandemics or whatever, that there is still appetite inside of the college to fund and support, tangibly support the initiatives that you've been excited by?
Yes. Okay, but I can elaborate. Yes. So what's interesting is that when you talk about, generations, when I go around to the different states and I talk to the students, the medical students that are out there, you mentioned in your slide about the comfort versus social justice. They are so eager to do the social justice part. Mm-hmm. So that helps me in my head. I'm saying to myself, oh my gosh, when they say, what's the best part of your job? Is going around the country and looking at these students and residents who are so eager to go out there and do the right thing and to make a difference in this world. And so I see this, and I know that they have slowly been coming up the ranks, and they're getting into leadership positions as they've moved up. And we also, with our, you say how we sustained it, we recently created we have a commission, DEI in family medicine. So that's the latest commission that was added to our group. And the difference here is that instead of meeting when all the other commissions meet, they meet afterwards. So the members of that commission are embedded in all the other ones. So the advocacy, health of the public and science, the education. So they're embedded there, and their job is to just keep an eye out, make sure, get feedback, and to kind of be that, that checkpoint to say, whoa, hold on, are you keeping this in mind as you do what you have to do, and then come back later on. They meet a day after everybody else, and then have their discussions and to look and see what's going on nationally, what's impacting different people, and say, okay, this is something that as an organization we need to pay attention to. We have our strategic plan, 9 items in our strategic plan. DEI is not a strategic plan because it is embedded in every single one. That was intentional. And so yes, if you have that, if you have to really, that's taking it to the highest level, understanding that whatever we do, we have to keep this in mind as we're working towards this. We will look around the room and we have to check ourselves. And when we talk about unconscious bias and implicit bias, I always raise my hand. It's like, being, when you go, a group of individuals who have to admit that they have an issue, this is also my problem. I say we all have it. So if you say that you don't have it, it's not true. We all have it. Have you ever driven down a highway and somebody in front of you is too slow and you're really pissed off because you got to get somewhere and finally they move out of the way? You don't keep going straight forward. You drive, you slow down, and you look. Yep. And then you keep going. Why? Because in your head you already knew who that driver was. Implicit bias. That's your thing. We all have it. So that's what I'm saying. So we have to keep checking ourselves. We will never be masters, but you have to keep checking yourselves. And at the same time, you have to keep checking your organization. You have to keep checking each other.
Well, I really like the comment, though, that you didn't ghettoize the agenda as this thing over here. You embedded it in all of the things so that it becomes organic within the organization. I'm going to come to you in a second, but let me just ask you again, Helen. This notion of medical education and the educational forms, are you comfortable as you sort of, and you have such a big vision, you see a lot of pieces, that the folks at AAMC, ACGME, ACCME, so the continuing medical, are those institutions of education, do they seem to have this on their radar?
Absolutely. I'm actually very confident. I think that, and in fact, when we went to, when Bonnie Mason and I went to the Macy Foundation for a grant around Equity Matters, it was actually very neat when they said, wow, the fact that you're doing, undergraduate medical education is the AAMC, but then you're working with ACGME all the way through practicing clinicians, faculty, because what you really need to do is you got to get the effector sites, right? You're getting medical students who are now getting this in medical school. It's part of the curriculum. They're starting to get it in residency, but if they're then hitting faculty for whom this is not part of the way they think, then there are no effector sites for them to actually make it work. So she was like, that's the special sauce. So yes, it's happening in medical school. It's increasingly happening in residency. But we've got to make sure that those in practice get it. So it's wonderful that AAFP and all the other societies now are embedding it for their boards, embedding it in CME. It's even starting to be on board exams. Like, you've got to get this out there, because otherwise those medical students are gonna, those, you know, racially justice-oriented medical students are gonna hit the wards and be like talking to attendings going, huh? Like, you're not getting what my mindset. This is what I've learned all the way through. It's got to be that full continuum, and that's what we're really committed to.
Neil, same thing from your point of view. What are you seeing in terms of the sustainability within the academy? And also, are you seeing in terms of education?
Yeah, it's a good and a challenging question to look at, you know, what is going to be the long-term vision. I want to frame it kind of in a broader context, coming from California, and just allude to what Dr. Jones said, and I'll get to medicine. You know, California has this reputation being a very blue progressive state. And in the post-war period in the 50s, if anyone doubts that there's a thing called structural racism that doesn't exist, you actually look at the deeds. I grew up in Palo Alto. I raised a family in Sacramento. The deeds literally say, you may not sell to a non-white person. I'm shortening that. So California has those roots in the 1950s, yet became the launching off point for Cesar Chavez and Dolores Huerta. So California has come a long way. And I think similarly in medicine, in terms of the, you know, the long haul, certainly in our area, I think we're just inspired by the framework and thinking about racism as a structural entity. That's really what preventive medicine wants to tackle. I think there's an excitement to take it on, because as we started with, it's essential to improving health and well-being for all, certainly the patients, the communities, and the population. So I'm optimistic. It's hugely challenging. But I think in our field, we are really just motivated to put what you described, Dr. Jones, into practice. And, you know, we're inspired, of course, by that tradition in California that I alluded to. That's why I mentioned it, of collective action. You can take on, you can look powerless as a farm worker and cut across the entire country and go way beyond farm worker rights. So that's why I made that allusion.
One last question, and then I'm going to, fair warning to the audience, they're going to hand me a microphone, and I'm going to come out there. And if you don't volunteer, then it'll be like when you were in junior high school, because then I'll just volunteer you. So be prepared. And also, you can also query our keynote as well if you have a question that you wanted to get at. I think that the real question, I think, in many ways comes back to this. I want to sort of dovetail back on the original question about why don't we just go ahead and practice medicine. And I think all of you are saying, as I heard you, that it is not possible to be a great clinician, physician, researcher, prevention specialist if you are not in sort of, you know, connected. But what do you see, though, as then, as you try to sell this beyond the humanitarian, for those that you cannot reach with the violin playing, the humanity, the appeal to the heart, but back to the heart and soul of being a clinician? How do you sort of see the relationship between being good at understanding racism and clinical outcomes?
Okay, so being good. Well, I think it's funny. I think at least our generation, the newer generation may be a little bit different, but our generation, we are very competitive, and we like to be really good at what we do. I mean, I'm not saying that the younger generation doesn't want to be good at what they do. It's just that we like to, that's why we have the metrics, right? We have metrics in what we do. It's to say, okay, I'm taking care of my population, I'm taking care of my community. And so in order to be the best that I can be, if I actively address racism, I can get there. And so I guess that's the final pitch, is to say, if you want to be the best you can be, the best physician you can be, the best public health individual that you can be, you need to tackle this. When you address this, then you will get there.
So Helen, I guess there would be beyond a yes answer, or no answer. Is it possible to elicit the history of present illness and/or communicate the therapeutic regimen to a patient if you, in fact, are racist and have a racist belief about that patient?
Ooh. I would say no, but that was not the question. I was still trying to work on your first question. But
do both. Go ahead.
I'll do both. I don't think you can. I think there are too many issues you're going to leave on you're going to ignore their environment. You're going to ignore their social determinants of health. You're going to ignore too many issues about them if you're too focused on the issue that you can't see beyond who they are to understand their full picture. But to your first question about can you ignore racism, I think you can't. And I think in some ways, in many ways, I think the explosion of what we've seen in terms of science and genomics and proteomics and all the rest of it, I think put all of this in a really interesting light. I think the work we've been doing with the Doris Duke Foundation and others around race and clinical algorithms is fascinating. Just this whole concept that, race is not a biologic construct, I think really kind of is an interesting way to frame it for some of these doubters. I think it's not a biologic construct. One of the most fascinating sessions we had at our recent meeting at the National Academy of Medicine is some of the work being done by the American Society of Hematology about, for example, this condition that isn't a condition of benign ethnic neutropenia. It doesn't exist. It's not a condition. It is, in fact, an ancestry buffy coat antigen of some folks who have ancestry from sub-Saharan Africa, right? So if you added that as something that's on the birth set of preventive screenings that we do on all babies, then none of those kids would ever be labeled as having a condition that we now label a condition, right? So this is an important prevention issue, public health issue. A lot of those kids and adults are actually told they can't take some of the most important new antipsychotics because they're in fact neutropenic. They're not neutropenic, right? They have perfectly normal white blood cell counts for their patient population and from where they're from. So if you get out of this mindset of race is not a biologic construct, and you take this much bigger vision of what science is bringing to the table, it may open up some of those other folks' minds because science is exploding in ways we've never thought about it. So if you're interested, I'm happy to share just a brilliant article by the researcher at Brigham Women's Hospital on this concept of benign ethnic neutropenia is not a disease. It's not. There's absolutely nothing wrong with people who have perfectly lower white cell blood cell counts for who they are. And it's not about their race. So.
Well, I'm going to go to the audience, but I just want to underscore and just leave dangling this other comment that's inside of your comment, which is the power to label.
Yes.
Isn't that an extraordinary aspect of this conversation? But
yes.
Doggone it, we don't have
It's the wrong label, though, right?
Mm-hmm. Say who you are, my friend.
Thanks, Reed. Yeah, Mike Parkinson, past president and colleague of many of the wonderful people in this room. But if I can call you Kamar instead of Dr. Jones, what a wonderful gift you've given us today. And for all the years of knowing you, thank you. Because I'm rife to say many of us, data tells, and we live in data, but stories sell.
Yes.
And it's the stories, right, that move people and bring us together. So thank you for the stories. And perhaps because I've never stared at Dan's smiling face for as long as I have listening to this, what comes to my mind as kind of a sentinel indicator for all of us, and I want to get your reaction to this. Dan, in many meetings I'd be in, we'd be there talking about topics that I thought I understood, and then Dan would make a comment that would engender what I would call constructive discomfort. And we can hear his voice, and you can see him tilt his head a little bit and say, well, and I felt dumbfounded and blindsided by the fact that I hadn't said or thought that. So does creating constructive discomfort, that's just my term, is that something we should strive to do in the right settings, in the right way, evidence-based where possible? The other comment or question, Helen, is recently I serve on the Defense Health Board. I most recently was the University of Pittsburgh, UPMC, and our 90,000 employees, and we do all the things that we're talking about there on the DEI and the discomfort and the training and all the types of stuff. But at the end of the day, where in the buzzword du jour of healthcare is now value-based care are the values that Dr. Jones is talking about. They're nowhere to be heard. And there's a cart and horse going on here about we can't really know how bad it is until we get the data systems perfect using the OMB classification versus the yada yada classification. I think it's a giant stalling tactic.
Okay.
Reactions, thoughts. Sorry.
No, you're good. So let me just do them in reverse order, and then we'll come back. I'll get to you in a second. On the last part of that, with the value-based reimbursement, and because it's a natural tie-in to where we just ended, around the notion of why is addressing this agenda well important and essential to be having good clinical outcomes. So.
I don't know whether I'm answering it correctly. I feel like I'm going to answer yours in part of that. Is that when we say about, like the codes, right? We've started to put in the social determinants of health codes, even though you don't get paid for it, which is a problem. But that's one of the things that we're trying to tell a lot of family physicians and telling everyone out there, code anyway, right? Put it in there because we eventually, those who control the purses, that's what they're going to look at, and so that's one of it. And hopefully, as we have the new as G2211, everyone. Okay, so but I'm just plug because that's part of it. But anyway, I think we're going to we have no choice. We have to do this. We have to. If they say that data is what they need, then do the data, and at the same time continue to do what we have to do on the other side, right? Have those uncomfortable conversations, constructive, uncomfortable situations, and try to explain to others how this will benefit them, right? At the end of the day, how does this benefit you as a physician, as a clinician, as a public health officer? How does this benefit you in what you need to do to get your job done? And then take it from there. That's
I would just hope, though, that if you're going to do value-based reimbursement and you're going to get successful, you've got to be dealing with social determinants. You've got to be swimming upstream. You got to deal with ideology that is fundamental within the society itself. And so I think, and you can't do any of that without addressing the racism agenda. So hopefully it's all going to be built in.
Just a quick, I completely agree with you. If we spend 1,000 hours just arguing over the codes of how are you going to determine the the strata, we'll never get to the actual business of it. But I think even if just institutions, clinics, hospitals just at least start doing it internally, be honest with yourselves so that you can't actually look at your own data until you yourself understand your own population. What's driving your readmission rates? How much of it is because some of your patients can't get their prescriptions filled? Some of your patients can't get to their physical therapy appointments. Be honest with yourself about what's driving those rates, even if it's not the way CMS is ready to do the full reimbursement yet. And there's a lot of stuff happening, with some of the value-based purchasing, some of the APMs that at least they're thinking about as part of the land. I'm hopeful that they'll at least start looking at it, but at least start somewhere, even if we can't get the big kahuna folks to move yet.
Let me get the Kamar to respond real quickly to the. I'm going to ask you to ask the question of, if you want, or somebody else can, around this discordance. And I thought that was a very provocative point. And I don't know whether you had a comment to make on that.
About the creating constructive discomfort.
Right, exactly. Do you have a comment on that?
Yes, I do have a comment. So I don't. Oh, sorry. Yes, about creating constructive discomfort. I will say that I like your framing. I personally never go out of my way to make somebody uncomfortable. What I do is I am courageous in speaking my truth. And so, and if speaking my truth is creating discomfort, then we can start there. So it gives me an opening to just say that there are 4 habits of mind for social justice warriors that I had wanted to present. I'll just say them in 30 seconds. I call them my 4 BCs, because it's BCs, you'll see. So they are: be courageous, speak your truth, be unafraid of controversy, embrace challenge, know that the edge of your comfort is your growing edge. So that's number one, be courageous. The second is be curious. Ask why, and then why again, and ask these serial whys so that you can not be satisfied with superficial explanations, but actually get to root causes. And then there are many other things about be curious, including read widely and read history and all of that. The third one is be collective. Care about the whole. So share your talents, your financial stuff, all of that with others, and there are many other things. Actually, be collective, organize and strategize to act is the linchpin of that. Like, recognize your individual's power, but be collective and organize and strategize to act. So that's the third BC, and the fourth is build community. So be interested, believe, join in the stories of others. So that means talk to strangers, burst through bubbles, speak up and take action on behalf of others, go across town and stay a while. So those 4 BCs are why I'm never intentionally trying to make anybody uncomfortable, but especially number 1, be courageous, speak your truth. I am on that day and night. So.
Thank you. Question? Sure. Tell who you are.
Thank you. Hunter Smith, U.S. Army. So I think, preventive medicine is a specialty and specialists that we're well positioned in terms of reaching out into communities and engaging at that systematic and population-based level, particularly for things like social determinants of health. So one thing that I'm constantly harping on and writing about is getting other physicians of other specialties that are far more clinically focused engaged in social determinants of health. The busy family medicine physician who's working day and night and then working it on notes even later into the night. How do we engage those specialties to really get into the communities, get into the populations, get into advocacy to help target those more upstream and systematic problems?
So
Neil, I was going to actually go to you, but I realized that at the end of that, he sort of got us into more of the specialty one. So I'm going to hold you a spot for a minute. Go ahead.
So yes, so we are doing that, right? So we have the Everyone Project, right? The Center for Diversity and Health Equity. We have the Everyone Project where it has tools. We have toolkits for our family docs so that they can figure out how to use social determinants of health to help create a better process for their patients. And so one of them is the Neighborhood Navigator. I don't know if all of you use that, the Neighborhood Navigator. So that's a tool that we teach in the medical students. We use it for the residents, and we have it free on the website you just plug in, and you have an app, plug in the zip code of your patient. What is the issue? Is it money, education, shelter, medications, the cost of medication, referrals to any social work, whatever, mental health, whatever it is? That's what we're showing them that even if they don't know how to do it themselves, give them something at point of care that they can use to take care of their patients. So yes, that is being embedded, and of course, we embed in a lot of the educational material we give. We have both the clinical training, but remember, maybe you don't know, sorry. We have two main journals. One is the clinical journal, and one is the practice management journal. And embedded in the practice management journal is how do you do everything we're talking about here? How do you do this? How do you actually do this in your practice where you are on a day-to-day basis?
Neil, are you seeing anything from a preventive medicine point of view of progress with some of the subspecialists deciding now that they need to be in the game? And I was sort of thinking as you were describing that, the pulmonologists now being aware that pulse oximetry needs to be looked at in a different way. What are you seeing?
Well, just a quick comment, because I wanted to ask Dr. Jones, being trained in both primary care and in public health, I really want to hear your reflections. Just as a quick comment is that I think there's a movement, I hope there is, the National Academy's report on whole health as an approach, not just about the VA, is something that primary care hospitalists and specialists could embrace, is saying that health, well-being is a much broader construct, and I think fighting racism would be part of it. But I just wanted to defer to Dr. Jones, having been trained in both areas and in public health. Because that's a great question. I wanted to hear your thoughts.
So if I'm understanding the question, my answer is that we need health services, but some of you might be familiar with my cliff analogy. So if a patient's falling off the edge of the cliff, we need the ambulance, the net, the fence. Those are our health services. We need to move the population away from the edge of the cliff. That's addressing social determinants of health. But we also need to recognize that we're dealing with a three-dimensional cliff. And at some parts of the cliff, there is no, either the ambulance has a flat tire, so it slower goes off in the wrong direction, or there's no ambulance, net, or fence. And usually at those parts of the cliff, the population is being pushed closer to the edge. So when we go from health services to social determinants of health, that's part of the way. That's moving the population away from the edge of the cliff, but we need to go further in acknowledging and addressing the three-dimensionality of the cliff, addressing what I at first called the social determinants of equity or inequity, which includes systems of power that can differentially distribute resources in populations like racism, sexism, all of the isms. So addressing social determinants of health like housing, income, that's important. But addressing social determinants of equity like who decided to redline, who's at the table deciding these things, that's the next level. So I guess my answer is we need people at all parts of the cliff. We need those ambulances to be really good ambulances in all parts and all like that. And so we need to train the clinical people. But even if you are training to be the best ambulance driver you can be, we need to ask, is there a net above me? How strong is the net? Is there a fence at the edge of the cliff? How strong is the fence? How close is the population to the edge? At what part of the cliff am I operating? Do I even do things when I'm operating at different parts of the cliff? So even if your day job is as an ambulance driver, we need to recognize the impacts of racism, social determinants of health, the primary, secondary, tertiary prevention, all of that. We need to understand as a system and as citizens, not narrow national citizens, but as people concerned about the whole, I'd say all of us need to first be concerned about the three-dimensionality of the cliff.
Okay. All right, we're going to try to do something that'll be impossible. We're going to squeeze 2 questions in and 2 answers in 4 minutes.
Okay, sorry for the question because it's hard to answer quickly.
But we want to hear
Chris
it, though.
Purnell on the Board of Regents for American College of Preventive Medicine. I find myself on New Jersey's Council for Reparations. And a part of my committee's question is, what does reparative justice look like in the healthcare space? We understand the social determinants of health, we understand those upstream factors, but part of my task is thinking through the lens of chronic diseases. And if New Jersey were to institute changes in structures, policies, practices, and norms, what does that look like? And you were one of the people in my head. I said if I could have this conversation, I would love to have it with Dr. Kamara Jones.
You know what I think we may do on that, because it is such a big one, is perhaps you all, first of all, I think it's important to get it on the record. The question on the record is essential. And I think what we may have to do, though, is to have you all do a sidebar, and then maybe there's a way to supplement this meeting with that response. I praise you for raising that. We're going to get this last one, and then the officials are going to gavel me.
This will be very short. My name is Dr. Peter Rim. I'm Director of Policy at the VA. And I work in the field of environmental medicine, mainly in toxic exposures. But we have just recently been pushing those in the decision maker to actually look at health inequity and racial, ethnic, socioeconomic more. And we actually have an interesting National Academies report coming up. I just want to put out, they're going to be looking for experts. It's going to be on mental health and the possible relationship to environmental and military and such toxicity. But they're actually looking for potential experts on racial and ethnic.
How soon will that be?
They're going to announce it in about a month.
So there's time to put the announcement in the newsletter that goes out to all the members, and thank you. So you make sure you connect with them. My 3 panelists, the lightning round, as we close out, you each get...
Did you hear that? I'm just saying, did you hear that? The 3 panelists.
The 3 panelists, I have, as I mentioned to you before, there is a lightning round, and I only have the 10 seconds, and I just lost 5 of them. What's the one thing that you said that you want everybody to remember, or the one thing you didn't say you'll kick yourself in the butt because you didn't? 10 seconds.
Everyone out there, we all need to invest and understand, learn about racism, act on it, and share the information. Don't stop.
There is incredible power by working together. We're stronger together by collaborating, sharing lessons learned, and making sure we actually make a difference.
10 seconds.
Collective action using a system approach that Dr. Jones said that's what we need to do.
And let the record state we ended exactly on time. Thank the panelists and the keynote speaker. Thank you all.
Thank you. Thank you so much, Reed. Before we close out and leave, let me say that as this third annual Daniel Blumenthal Lectureship ends in health equity and social justice, I've got to thank a number of people. I want to thank our three panelists, Dr. Iruka Malizi, Dr. Burston, and Dr. Kahatsu. Let's give them a nice round of applause. Thank you. We also need to thank our moderator extraordinaire, Dr. Reed Tuckson. Thank you as he races to the door. And of course, we at the ACPM are grateful and delighted to have heard and to have learned from her allegories, this year's awardee, Dr. Kamara Phyllis Jones. Thank you so much. I want to thank the entire ACPM staff, in particular Kathy McMahon-Gage, and the rest of the ACPM staff who've put this program together. Also, ACPM CEO, Donna Grande, who was unfortunately unable to attend in person, but she's online, so thank you, Donna. We really appreciate it. Let me thank the audience both for coming to the National Press Club here in Washington, D.C., those folks who are also online on the live stream, and for the folks who were brave enough to ask the questions. Thank you all. We're going to make sure Chris gets an actual answer next door. Thank you all. I want to conclude with a few points. I think I'm just echoing what we have heard. Racism has a strong negative impact on health. As medical doctors, we cannot forget that. We also have, as we've heard, a moral obligation. It's an ethical imperative to dismantle structural racism. Also, while there is pushback when we hear about the anti-woke efforts, progress is being made. It is not easy, and it's a constant uphill struggle. But as Dr. King reminded us, the arc of the moral universe is long, but it bends towards justice. And so we should keep that in mind, especially on the toughest days when things seem to roll back downhill. And lastly, we have heard a little bit about the quality of care. We heard in preventive medicine, we used the construct from Don Abadian, from JAMA in the late 1980s, structure, process, outcome. From Dr. Jones, we've learned about structure, policy, practice, and the need to act. And I'll close with an author from about 200 years ago, and no, I was not a young boy then. Johann Wolfgang von Goethe wrote, "Knowing is not enough. We must apply. Being willing is not enough. We must do." So let's continue to do the work, and it is hard work, to do the work to dismantle structural racism and thus improve the health and well-being of our patients and our communities. Thank you very much. Let's go together next door for a little bit of food. We really appreciate it. Thank you. Thank you.